A very good afternoon, everyone, and I think, yes, I will cover that, but this is the outline of my presentation. So I'll first highlight on the impact and late presentation of liver cancer. I will then focus on the changing epidemiology and look at its related factors, which includes screening for the common HCC risk factors within the community level especially, with the ultimate aim of prevention and early detection of HCC. I will then actually focus on how we bridge the gaps between fatty liver disease, HCC, and NCD strategies, ending with an emphasis on the topic at hand, which is the stakeholder partnerships for a cohesive approach to tackle liver cancer. So this is the latest global cancer statistics, which show that liver cancer is the third leading cause of death in Malaysia. So when you look at, we had a sneak preview last Friday on the latest NCR report, which has yet to be published, and it showed that liver cancer is the fifth most common cancer, rising from number 8. And this is really worrying, suggesting an increasing trend, which is exactly what is in keeping with the global trend. So alarmingly, liver cancer cases and deaths are increasing worldwide. So the new liver cancer cases and deaths have increased by a whopping 100% between 1990 and 2017. And more recent data has showed that this incidence and death will continue to increase over the next few years, driven mainly by population aging and growth. So undoubtedly, HCC is extremely deadly. And again, looking at the incidence and mortality, you can show most of the data will show that it's nearly equal, underscoring the poor prognosis of HCC. So why is HCC so little? So I think it's well-known knowledge that up to 90% of HCC arise in cirrhotic livers, and the underlying liver disease or cirrhosis is often not diagnosed at the time of presentation. Now, HCC usually involves multiple foci and unfortunately will rapidly progress to invade blood vessels in the majority of cases. But what makes HCC particularly lethal is that a high proportion of cases are diagnosed at a very late stage, and the main reason is the majority is not detected as part of HCC surveillance program. So this study showed that up to 70% of cases presenting with HCC for the very first time had symptoms, and these symptoms can either be due to the late stage of the cancer itself, or the underlying liver disease, which is already late stage as well, and giving rise to the symptoms. So if you look at the actual staging in this study compared to Japan and US, we have nearly 50% of patients presenting with HCC at an advanced stage, what we call BCLC stage C and D at first presentation, with a 5-year survival rate, which is abysmal, only 12.8%. So again, to stress why this is so is because that liver cancer surveillance is very much underutilized in clinical practice. And you can see from this study that only 21% of our patients in Malaysia from this study were on any sort of surveillance program. And that's even lower than the pooled surveillance estimates from this study, from the systematic review of 26%. Still not high, but ours even lower. So let's now look at the changing epidemiology of HCC. So this slide shows the underlying causes of liver cancer at a global level. So hepatitis B accounts for the majority of cases at 46%, followed by hepatitis C in 29%, 17% alcohol, and 17% others, which mean other causes of hepatitis. So these are signs of modern times, with increasing number of individuals, and this is reality, both adults and children with expanding waist circumference. So non-alcoholic fatty liver disease, or the preferred nomenclature of metabolic dysfunction associated fatty liver disease, or MAFLD, is a huge public health problem. And it's actually now been shown by many studies to be the fastest growing cause of HCC. And I'll show you a few more data on that. So these 3 studies from one sector showed the changing pattern in the underlying cause of HCC. So hepatitis B remains in these 3 studies as the commonest cause, but you can see from the latest study on the right that MAFLD, or metabolic dysfunction associated fatty liver disease, will probably soon overtake hepatitis B as the commonest cause in the very near future, if it's not already happening now. And you can see here, hepatitis B accounts for 44% of cases, and with oops, what happened here? Sorry, can you go back to the slideshow? And followed closely behind with fatty liver disease in 42%. So this is really worrying. So these studies show the changing course of the underlying chronic liver disease associated with HCC, and is very much a global phenomenon. So this study from England at the bottom, at the top are some of the studies from US showing rising prevalence of fatty liver disease. So to get an idea of the quantum of increase, similar to what we have shown, is that this very recent German study that was actually presented this month during the European Liver Meeting showed that patients with fatty liver showed a 3.7-fold increase over 16 years, contributing to the HCC burden. So this is really dramatic and definitely should be raising alarm bells everywhere, including in Malaysia. And again, to stress, what's the cause? Is very much globicity. And the global obesity statistics are getting scarier even in Asia. We're no longer in the green zone. And even this study at the bottom from a few years back showed Malaysia is leading in adult prevalence of overweight and obesity amongst these Asian countries. And the latest data from the National Health and Mobility Survey that was just published early this year showed that definitely we are getting fatter, with increasing prevalence of adult obesity now stands at 54%, and this is in parallel with the rising rates of MAFLD. Now, for the very first time, the NHMS data has included MAFLD, and this is actually an important part of the recognition that it is another NCD. And if you can see why that is so, if you look at the global prevalence of MAFLD, it affects 1 in 3 adults globally. So this is the latest data that we have on MAFLD. And similarly, in Malaysia, 3 in 10 adults have MAFLD. But what is also important to really stress is the association of MAFLD with other NCDs, particularly heart disease and cancer, that I will be focusing for this presentation. So why do we need to integrate, and how do we do that, the fatty liver disease in NCD strategies? Again, showing this data from the National Health and Mobility Survey, there is no doubt that MAFLD is closely related to highly prevalent NCDs, particularly abdominal obesity. So you can see at the bottom left-hand figure that is again similar to the prevalence of obesity. Abdominal obesity is also 54.5%. And if you look at the sheer burden of people having all 4 diseases shown here, is over 500,000. And these are the drivers of MAFLD that we have to take note. Okay, and looking at what are the actual prevalence, if you look at the individual cases of people with obesity and diabetes, it is extremely high, up to 90% MAFLD prevalence in people living with obesity, up to 70% of MAFLD prevalence in people with type 2 diabetes. So we've been focusing only on the major adverse liver outcomes, but we must not forget that being the hepatic component of metabolic syndrome, you will see the same risk, or rather, what are the deaths that's going to be associated with this problem. And that includes, of course, again, heart disease, stroke, and cancers. So what I would like to focus here is that studies have shown that fatty liver identifies those at risk of cardiovascular death. Oh, I have running behind. So very quickly, up to 45 prevalence, and the top of heart disease in this group, top causes of death are cardiovascular and malignancy, and followed only third by liver related. So you need to look at it holistically and must be integrated in the NCD programs. So what about identifying fatty liver disease and those at risk of cancer? So the inclusion of fatty liver disease screening in the clinical management of type 2 diabetes mellitus really provides a great opportunity to raise the alarm on fatty liver disease. So what it does, it actually recommends screening using just simple blood test, ALT, AST. So when you include age and platelet count, then you get what is the FIB-4 scoring, and based on that, you can see that those with high FIB-4 count greater than 3.25 predicts those with advanced fibrosis and cirrhosis and who are also at risk of HCC. So in routine clinical practice, everyone suspected to have MAFLD, or particularly with raised ALT/AST, will be also screened for other liver disease such as hepatitis B, C, and alcohol, which also forms the HCC risk factors. And so we can get this screening not just for fatty liver, but also for the other HCC risk factors. And this is a simplified algorithm on how to do that using just ALT, AST, and platelet count. And you can see from the top there, the ultimate aim of this screening is not just about identifying the risk factors, but really intervening. That means making sure that these patients should be treated to stop the progression. And not many has associated that. I'll give an example. Hepatitis B, if you detect it early enough before they develop cirrhosis, you have an 80% chance of reducing the risk of HCC. So this must be looked at as a form of prevention of HCC. Secondly, you also must look that you are also identifying those at risk of HCC and putting them in a surveillance program to have early detection. Oops, again. I think I've gone to the end. Hang on. Okay, I'm good. So you also have to remember that you can also predict those at risk of HCC who must undergo surveillance. So my second last part of the presentation is about bridging the gaps between fatty liver disease, HCC, and NCD strategy. So very quickly, this consensus statement have included recommendations on how to advance the MAFLD public health agenda. But I'd like to just draw your attention to what is really an important... So sorry about that. I keep on pressing escape instead of the laser button. That's why I know now. Okay. So what I would like to show you is on the far right, that it also really emphasized that the policy strategies and whole of society approach must be addressed holistically and incorporating this into the NCD agenda. And the great example is on the integration of fatty liver disease in the National NCD Prevention Program is by the government of India. And they have introduced way back in 2021 the alignment or the integration of the strategies needed to address fatty liver into the National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Diseases, and Stroke. So the last part, very quickly looking at how we're going to look at partnership approach to tackle liver cancer. So basically this is just very simple pillars of the strategic framework that's been proposed with the key action plan needed, and this is what I've been talking about is actually really on pillar 2, the optimizing HCC prevention and early detection by scaling up detection of HCC risk factors. But the other modalities to reduce the cancer burden for liver cancer overall must include positioning the HCC response with data, using MDT approach to HCC, and creating an enabling environment for people to come together. So this is my last slide. To conclude, the changing pattern in the epidemiology of HCC is largely due to the rising prevalence of MAFLD, and we have shown the example on scaling up early detection and management of the HCC risk factors to optimize HCC prevention and early detection. So there's substantial overlap in the public health and clinical management required to address MAFLD, HCC, and other major NCDs. So you need to have a stakeholder partnerships to decentralize the screening in the primary care setting, and this can serve as an integrated model on a holistic approach to NCDs. With that, thank you.
You have any questions? Yes. Oh, you have a question? Yes. Go ahead. Or do you need a microphone?
No, you can hear me, Prof?
Yes, of course.
Thank you so much, Prof, for that presentation. My take-home message is that surveillance is definitely one of the key criteria that we need to address. I'm wondering, and you've already shared what or how patients should be identified before they get into the surveillance program. I'm just wondering how uniform or compliant is surveillance throughout the Malaysia healthcare system, knowing that we have our primary GP, the private center, we have our clinic kesihatan, we have our primary care, tertiary, secondary hospitals, tertiary hospitals. So I'm just wondering how uniform is surveillance as a concept?
Okay. I don't have data on the overall approach, but I can tell you that currently the surveillance for HCC is mainly restricted in the tertiary care setting. So amongst gastroenterologists and hepatologists, it's routinely done. We do this even, same like hepatitis B, those we identify to be at risk will undergo HCC surveillance. For people with MAFLD, for example, we identify first those with advanced fibrosis and cirrhosis, but currently most of the international guidelines only focus on surveillance for people with cirrhosis. Although we know that nearly 40% of HCCs arising in MAFLD-induced HCC occur in non-cirrhosis. So that's why we need to really stratify further. So that's one. We have to not dissociate, but really look at the two different roles. There's a definite role for primary care providers. And the reason for using fatty liver disease as an example is that this is the way that now you can actually really decentralize and amplify the healthcare providers in the community, which are mainly the family physicians, the GPs, to identify those with fatty liver using the simple recommendations from the type 2 diabetes CPG. And that's already started to be done. Not widely, but the use of FIG4 as a first line risk stratification is a great way of identifying those at risk among those with chronic liver disease. So we cannot be doing surveillance for everybody. First, we need to identify the risk group by identifying who are the people at risk. Yeah. That answer your question, the second part?
Just so that I understand. So we're saying that it's the surveillance is pretty uniform, but that's in the tertiary care. But the risk stratification in the primary care using the FIG4 algorithm, that's still, what I'm hearing is that it's still not uniform yet.
It's not, because we have to identify what are the gaps, what are the difficulties. And you think that AST and ALT are quite simple and widely available, but when you actually do talk to the primary care physicians, and so we did the pilot in Sabah, Terengganu, and also Penang. Penang was mainly because of the northern part. We wanted to see what are the difficulties. You know what's the commonest barrier just doing the Fit 4? Because most of the clinic kesihatan, the blood test, does not include AST. But we actually also had people who are very much aware of this and ordered just AST, ALT instead of the full LFT. That is even half the price of the full LFT. So this is how we need to discuss with other champions to actually look at CAMPATH. Can you make sure that when this is done for screening, make sure that the AST is available in this setting, and then only talked about getting the automated Fit 4 calculation done. So that's the second step, but can be done and has been done, fortunately. Any other questions?
I think that will conclude our talk. There will be sorry. So thank you, Prof. Dr. Rosmawati.